Welcome everyone to the BioFire FilmArray Pneumonia Panel Healthcare Provider Medical Education Module. I am Christine Giannacchio. I'm the Vice President of Global Medical Affairs for bioMérieux and for BioFire. One of the main questions that we really need to ask is why having a pneumonia panel is actually so important. And mainly that's because if you take a look at the global burden of respiratory infections, you can see that it's the fourth leading cause of death globally, with a huge impact only behind that of ischemic heart disease, stroke, and chronic obstructive pulmonary disease. It's the fourth cause of death worldwide, the second cause of death from an infectious disease worldwide, and sixth in the United States. And it represents approximately 29% of all infectious diseases. There's a very large clinical and economic burden for pneumonia. Data from the United States has shown that there's approximately 4 million cases per year, with over 1 million hospitalized patients, leading to about 5,000 deaths. And on the financial side, this costs roughly about $10.2 billion per year, at an average of about $35,000 for patients that are admitted to the hospital, and overall about $2,500 for all patients. Traditional microbiology, we know, can take days and can be often inconclusive in providing an accurate diagnosis of the causative agents of lower respiratory tract infections. In a study by Jane et al., they looked at community-acquired pneumonia requiring hospitalization among U.S. adults. This was a CDC-funded study to look at the etiology of pneumonia using culture for bacterial identification. About 2,500 pneumonia patients were enrolled, and they identified a pathogen in about 38% of those patients, and only 14% of patients had a bacteria identified. If you take a look at the graph to the right, you can see that viral co-detections were roughly 2% of the patients, bacterial viral co-detections 3%, viral pathogens only about 22%, fungal or mycobacterial detection 1%, and a large burden has no pathogen detected, approximately 62% of the patients in this study. There was a nice quote from the authors that really emphasizes the need for better diagnostics. They stated, "The low pathogen detection yield among adults who are hospitalized for pneumonia highlights the need for more sensitive diagnostic methods and innovative discovery of pathogens." In an additional study done by Jane also, but this time looking at community-acquired pneumonia requiring hospitalization among U.S. children, this study highlights how traditional microbiology also needs molecular testing to increase diagnostic yield. The study was from January 2010 to 2012. They enrolled over 2,600 children, and approximately 2,400, or 89%, had radiographic evidence of pneumonia. The median age was 2 years. 21% of the children required ICU admission, and less than 1% died as a result of the infection. About 2,200 children with radiographic evidence of pneumonia had specimens available for comprehensive culture and for molecular testing for bacteria and viruses. If you take a look at the chart on the right, you can see a different pattern when we add in good molecular diagnostics, and particularly in a pediatric background. In the patients with just one viral pathogen identified in the dark blue bars, you can see that that was primarily in the younger age group of children under 4 years of age. The next group was viral co-detections found in both age groups, again higher in the younger age setting. Bacterial pathogen only, relatively low in children, but higher when you reach the 5 to 17 years of age. And overall, they had very good diagnostic yield, with in younger children, a pathogen generally detected about 80% of the time. So in this study, a viral or bacterial pathogen was detected in 1,800 of the children, 81%. One or more viruses in 66%, bacteria in 8% of the children, and both bacterial and viral pathogens in about 7%. The BioFire Pneumonia panel is fast. From time of sample addition to result takes approximately 1 hour. Data from our clinical studies have shown that it's accurate. In bronchial alveolar lavage specimens, the sensitivity is about 96.2% and has a specificity of 98.3%. In sputum, a sensitivity of 96.3% and a specificity of 97.2% for the pathogens present on the panel. It's quite comprehensive. There's 33 targets. We can use 2 different sample types, sputum including endotracheal aspirates and BALs including mini BALs. And we'll talk a little bit more about this later. It's also semi-quantitative, reporting DNA copies per ml for 15 specific bacteria. This is a list here of the panel menu and the different sample types. The bacteria that are semi-quantified are listed in the left column. Acinetobacter, Enterobacter cloacae complex, E. coli, Haemophilus influenzae, Klebsiella aerogenes, Oxytoker and Pneumoniae group, Marxella cataralis, Proteus species, Pseudomonas aeruginosa, Serratia marcescens, Staphylococcus aureus, Streptococcus agalactiae, Streptococcus pneumoniae, and Streptococcus pyogenes. The atypical bacteria are reported qualitatively, positive or negative, and that includes Chlamydia pneumoniae, Legionella pneumophila, and Mycoplasma pneumoniae. All the common viruses are present: adeno, the coronaviruses, human metapneumo, human rhinovirus enterovirus group, influenza A, influenza B, all the 4 parainfluenza viruses, and respiratory syncytial virus. There's also detection of very specific antimicrobial resistance genes, including methicillin resistance, where we detect both the MEC-A and the MEC-C genes, and MREJ, which is the junction that links the staphylococcal chromosomal cassette in the Staph aureus itself. So we can now actually show that the MEC-A and MEC-C are present in Staph aureus and not in coagulase-negative staph that may also be present in the sample. We have markers for the most common carbapentamases, IMP, KPC, NDM, OXA48-like, and VIM. And also one of the most common found ESBLs, CTXM. The 2 different validated sample types that I mentioned are going to be sputum-like, and this can include expectorated sputums or induced sputums and endotracheal aspirates. Bronchial alveolar lavage or BAL-like specimens, including mini BAL. Now, one of the most important things in the design of this assay was being able to accurately quantify in a reproducible way the amount of the bacteria that are semi-quantitated that are present on the panel. And to do this, a very specific flock swab was designed. It's provided in the kit. This flock swab is used to swirl and collect a standard amount of sample that is then added into the sample buffer before the start of the assay. The BioFire Pneumonia panel intended use: it's to aid in diagnosis of lower respiratory tract infections. It's for use on patients with signs and/or symptoms of lower respiratory tract infection. And it should, of course, be always used in conjunction with other clinical and epidemiological information, and not as the sole basis for diagnosis, treatment, or other patient management decisions. What patient populations can be tested with the panel? Nicely, it includes all ages, from young infants through geriatric patients, and it can be used across multiple settings. This includes testing in outpatients when indicated, patients coming through our emergency departments, and also our hospitalized patients. Now let's talk a little bit about what we call semi-quantitative reporting. And the reason why semi-quantitative reporting is important is because we know that a lot of the pathogens that are listed on the panel can colonize both the upper, lower respiratory tract and may not be the actual cause of the disease. So the BioFire Pneumonia panel contains an internal quantified standard material, which we call the QSM. And the quantitative values for the bacterial targets are calculated by comparing the real-time PCR data of the QSM relative to each individual target. These calculated values are then rounded to the nearest 1 log, what we call a bin. And the picture down here explains the divisions of the bins. So the lower end of the bins is roughly about 10 to the 3.5. Anything below that will be reported as not detected. It may be present in the sample but would not be reported. And then the log bins will be 10 to the 4th, 10 to the 5th, 10 to the 6th, and greater than or equal 10 to the 7th. So where does the concept of bin reporting come from? And this is a long standardized microbiology method that we've been using in the clinical lab for probably close to 30 years. And in many laboratories, particularly for true lower respiratory tract samples, such as BALs or mini BALs, we do quantitative culture. And based upon these quantitative cultures and clinical indications, certain cutoff values were set to suggest whether or not a particular pathogen is likely to be significant. So, for example, if you look at the first, which is sputum, it could be expectorated or induced. There's many different things that we look at to evaluate how appropriate that result is as the cause of the disease. So likely to be significant would be if it was the predominant pathogen on gram stain, say a gram-negative rod, and then we grew it in culture. If we did a quantitative culture, the cutoff is roughly about greater than or equal 10 to the 6 colony-forming units per ml. And on the gram stain, we would see abundant number of neutrophils or white blood cells. Not likely to be significant if the predominant pathogen was not present on the gram stain, and there was what we would normally report as maybe a 1 to 2 plus growth in culture, or rare or few colonies seen. Less than that 10 to the 6 CFU per ml, and neutrophils would not be abundant. Additional information that could help us suggest possible significance would be whether or not on a gram stain we saw a potential pathogen within the neutrophils, particularly in the polymorphonuclear leukocytes or intracellular, and then also whether or not there was a lack of normal flora on the culture. Now, these quantitative culture values will differ depending upon the sample type, where you can see here when we get into true lower respiratory tract samples, such as bronchial alveolar lavage, the cutoffs are much lower because they're much cleaner specimens and do not have as much oropharyngeal contamination as we see in things like sputum and endotracheal tube aspirates. So for here, the cutoff is greater than or equal 10 to the 4th CFU per ml for what we would normally report. Now, this type of reporting can vary tremendously depending upon the clinical status of the patient. It may depend upon what unit the patient is in the hospital. It can depend on individual requirements in particular institutions. So your regional requirements may be different. Your own laboratory may have different reporting requirements. And across the world, there are different levels of cutoff values. So for instance, in France, their cutoff values that are recommended are a little bit different than what's recommended in the Manual of Clinical Microbiology. So how precise are we when we assign a bin value to the particular pathogen? So there were a number of experiments that were done to look at the distribution of these measured values and the percentage of the bin precision for 90 replicates of 3 different bacteria that were tested. So Staphylococcus aureus, Pseudomonas aeruginosa, and a more fastidious organism, Haemophilus influenza. And these were tested at 6 different dilutions. So if you take a look at scenario 1, the graph to the left for Staphylococcus aureus, that was done with a value that was approximately right in the center of the bin. In the second group, scenario 2, Pseudomonas aeruginosa, approximately 60 to 90% for semi-quantitative values between a bin limit and a bin center, which would be, an example would be roughly, say, about 10 to the 5.25. And then we would expect 50% for semi-quantitative bin value limits that would be right at the edge of the bin. So roughly approximately 10 to, say, 5.5, which is shown in scenario 3. And you can take a look nicely at the different graphs and how the replicates actually were highly reproducible within the bin. So in scenario 1, greater than 90% as expected fell within the correct bin. 60 to 90% fell within the correct bin value when it was somewhat off-centered at about 10 to the 5.25, and when the value fell right at the edge of the bin, you could see that 50% of the time the results would be in one bin versus the adjacent bin. Now, there are a number of antimicrobial resistance genes that are present on the panel. So for ESBLs, we have one marker, CTXM. We all know, and we have to keep in mind, that there are many hundreds of enzymes that are related to ESBLs, but in the panel we do have the marker for CTXM. And the pathogens associated with the potential to have that marker, the bacteria are listed below it. For the carbapentamases, we can report KPC, VIM, IMP, and NDM for the same list of pathogens. And for OXA48-like, we can report Enterobacter cloacae complex, E. coli, the Klebsiellas, Proteus, and Serratia marcescens. And then, as we discussed previously, for the beta-lactam drugs for methicillin resistance, for Staphylococcus aureus, it's the MEC-A, MEC-C genes that are detected in combination with the staphylococcal chromosomal junction, which is MREJ. We need to keep in mind that a resistance marker or markers are only reported if a microorganism is detected that could potentially contain that resistance gene. So, for example, if none of the pathogens that are listed under the KPC carbapentamases was detected, we would not report a KPC positive. One of those pathogens would have to be there. The other thing that we need to keep in mind is that we cannot directly, definitively link the resistance marker to a particular pathogen that is reported. So, for example, we may report an E. coli, we could report a KPC, but we cannot 100% say that that KPC is present in that E. coli. If we have multiple gram-negatives, say for instance a Klebsiella pneumoniae and an E. coli, again, if we report a KPC, we would not be able to say that the KPC was in either the E. coli or in the Klebsiella pneumoniae, but it is present in that particular sample. Now, one of the key things with these resistance markers that's really becoming very important is that currently we have a lot of new drugs that have activity against the different carbapentamases, which have been extremely difficult to treat those organisms with those enzymes. But in order to be able to select the appropriate therapeutic choice, it's really important to know the genetic mechanism of resistance, because not all of these new drugs have equal activity. So on this graph, I just picked a couple of examples of some of the newer drugs and what classes of ESBLs or carbapenemase enzymes are they effective against. So a green check mark, active for most isolates, a red bar through a circle, inactive for most isolates, and then the combination of both would be variable. So, for example, ceftolozane tazobactam has activity against ESBLs, but it does not have activity against Class A serine carbopentamases, which would be something like a KPC. It does not have activity against Class B, the metalloproteases, which would be, for example, NDM1, VIM, and IMP. But it does have activity against Class C, which, for example, would be OXA48 and Class Ds. It has activity against Pseudomonas, but it has variable activity against Acinetobacter baumannii. So it's very important that you understand the spectrum of activity for all of these different drug compounds. But now we can provide you with that genetic information to help you make very accurate selections. This is an example of the sample report that is generated from the BioFire FilmArray instrument. The semi-quantitative analytes, the bacteria, are present at the top of the report with a graphic representation. So, for example, if you take a look at this report, Klebsiella oxytoca was detected at greater than or equal 10 to the 7th, and Pseudomonas aeruginosa was detected at 10 to the 6th. Below it are the antimicrobial resistance genes, and there were none detected in this particular assay. There were no atypical bacteria detected, but under the viruses, you can see that we detect a coronavirus. Now, we have to keep in mind that there are other pathogens, of course, that can cause lower respiratory tract infections that are not present on the panel. So we cannot exclude other types of infections. And there are additionally other resistance mechanisms that may be present that we also do not detect. A good example is in Pseudomonas and Acinetobacter, where a significant amount of resistance may not be mediated by these enzymes, but may also be mediated by pouring down regulation and efflux pumps. So we have to always keep that in mind when we interpret a negative report for antibiotic resistance genes, that there still may be potential for resistance to those particular classes. The report will be 2 pages. The first page will have a detection summary and showing only those detected analytes, but the second page, as you see here, has the entire report. So now I'd like to go through with you the BioFire Pneumonia Panel clinical evaluation that was performed to evaluate the assay for both the FDA submission and for CE marking. The study design, the samples were collected at 8 sites across the United States. They were geographically distributed. And we did quantitative culture was performed at an additional single reference laboratory to ensure that all the testing was done exactly the same. We captured relevant patient information such as comorbidities, their demographics, and what type of healthcare setting. We also captured, in addition to the reference laboratory quantitative culture, also the data on how the routine cultures or the standard of care lab results were at each one of the individual testing laboratories. And this included their gram stain and also their standard of care culture. And this could have varied tremendously depending upon the individual laboratory. All the samples were tested prospectively. All the samples were shipped to the reference lab for the quantitative culture, where it was done on 4 different agar plates with 4 dilutions per plate. And then the samples were also analyzed with an additional independent quantitative molecular comparator. This is the demographics from the clinical study. Again, we were enrolling the residual specimens, sputum, ETA, BAL, or mini BAL, that were submitted for routine culture workup. You can see here very nicely there was a diverse age group so that we would be able to assess the performance even in very young children, less than 5 years of age, up to the elderly, and in both a number of clinical care settings, whether the patients were hospitalized, they were outpatients, or seen in the emergency department. The pneumonia panel had a high sensitivity and specificity. The performance values were calculated compared to both molecular or culture-based methods, depending upon the analyte. There were fundamental differences that exist between measuring genome copies and viable organisms that we'll discuss further, but overall, the positive percent agreement, the sensitivity for the BAL samples overall was 96.2%, and for sputum, 96.3%. The negative percent agreement, or what we call specificity, 98.3% for BAL, and for sputum, 97.2%. One of the things that the studies certainly showed is that more potential pathogens are identified. And this is due fundamentally to the differences that we see between sensitive PCR and culture. We know the BioFire Pneumonia panel will detect more organisms than in culture. So if you take a look at the graphs to the right, in the BAL specimens, 16% were positive by both techniques. 22% were positive by the BioFire panel only. About less than 1% were only positive by culture, and about 62% of the time, both techniques were negative. In sputum, you see somewhat of a higher recovery yield, with 34% detected by both techniques, 27% detected just by the BioFire Pneumonia panel, less than 1% by culture only, and 39% with both culture and the pneumonia panel being negative. There were 875 PCR-positive culture-negative specimens that were determined in the clinical study. However, these would technically be considered false positives because they were not grown in culture, which would be considered the gold standard. But of the 875, 871 were resolved in favor of the BioFire Pneumonia panel upon further investigation with independent molecular comparator methods, showing that what we detected was truly present in the clinical samples. And a good example to illustrate this is with Haemophilus influenza. There's quite a bit of difference between culture and PCR. We had 163 BioFire Pneumonia panel, what we would call false positives when compared to culture. But we do know that Haemophilus influenza is a very fastidious organism. It can die very quickly if cultures are not plated rapidly, and can be also difficult to recover in culture. The discordance between the BioFire Pneumonia panel and culture was resolved again using an independent molecular method. And what we found is that in those 163 instances where we did not grow Haemophilus influenza, we were able to confirm the presence of Haemophilus influenza in 160 of the 163 samples. We also found multiple pathogens per sample were identified, and it was rather quite frequent. Viruses and bacteria were observed together in 6% of BAL samples and 20% of sputums. The rate of multiple bacterial detections in single specimens was higher in sputum, 19%, as you would imagine, compared to BAL, which was 12%. And multiple viruses were observed in both samples, but at a low rate of less than about 1%. So if you take a look at the profiles to the right, the one in blue, which is for BAL samples, 21% single, multiple 12%, single virus 9%, multiple virus 1%, and multiple organisms, virus and bacteria, about 6%. When we look at the other graph for sputum specimens, single bacteria in 21%, multiple bacteria in 19%, single virus in 10%, multiple viruses 1%, and multiple organisms, viruses and bacteria in 21%. And in the chart down below, you can just see that the overall percentage rates are broken up by the number of analytes, which of course for BAL, the majority having 1 or 2 analytes, where with sputum, we see a little bit more where we have 1, 2, or potentially 3 analytes in a particular sample. One thing that we have to keep in mind is that copies, we're measuring DNA copies, are not equivalent to the colonies that we grow in culture methods. And that's to do with the technique. With PCR, we're detecting both live and dead viruses, and also with some of the subjectiveness and some of the differences in culture methods. PCRs detect a sequence of nucleic acid, and unlike culture, we don't require that viable organism. So what are some of the possible reasons PCR detects organisms that culture does not? The organisms are fastidious. Perhaps the patient had already been treated empirically before the culture was collected, so they're on antibiotic treatment prior to sample collection. There's also variability in normal oral flora definitions and reportings from laboratory to laboratory. Sample transport conditions can greatly affect the recovery of organisms and also certain patient immune factors. If you take a look at the results of our semi-quantitative bin values as compared to another molecular method, what we see in these graphs on the top is that the BioFire quantification, the raw values, compared to a molecular method, really compare quite nicely. You can see that most of them are right along the axis with good correlation, whether it's in a bronchial alveolar large sample or in a sputum sample to the right. However, when we compare it to quantitative culture done by the reference laboratory, you can see that in both the BAL sample and in the sputum sample, that correlation is not as consistent as what we see using a comparable molecular method, with definitely a shift to the right for the majority of the samples you can see here, indicating that as a general rule, we tend to see a little bit higher quantification in a molecular method than we do when we do quantification by culture. Now, this is not in every sample, and this is not standard for every pathogen, but there is this general shift that we tend to see. So let's take a look at the comparison to quantitative molecular testing by looking at the comparator quantification with our comparator assays versus the bin results. And if you take a look at BAL on the top, you can see that the majority of the results correlate quite nicely across 2 consecutive bins that are highlighted in green. If you look at sputum, again, the quantitative molecular values versus the bin values, again, they tend to fall within 2 adjacent bins pretty much equally across the dynamic range of the assay. This slide shows the comparison of the FilmArray Pneumonia panel binning to standard of care culture. So these are the results from the 8 medical centers participating in the clinical study in looking at over 1,600 specimens. Each of the laboratories reported based upon their routine processing code. The results could have been reported as few, moderate, many, 1 plus 2 plus 3 plus, but these varying semi-quantitative reporting schemes were standardized to compare it to our bin values. If you take a look at the charts now on the right, in both the BAL and the sputum, you will see that some of the results do fall within a 1 and a 2 log bin. However, a little bit different than in our quantitative results, we tend to see a larger spread with some of those results falling across 3 bins, and on average, the BioFire Pneumonia panel results tending to be a little bit higher than what we see with our semi-quantitative culture results in the laboratory. Now, the next couple of slides, I'd like to talk to you about some real-life data that we're currently in the process of evaluating. And this was from an evaluator program where laboratories around the world were able to use FilmArray pneumonia panels and compare it to their in-house routine laboratory testing for lower respiratory tract samples. So what I've done, I've just selected a few examples to show you how the results can be the same and how they can be different. So in this table, I have comparisons of concordant results for the analytes that are on the BioFire Pneumonia panel. So for example, in sputum, by culture, they detected Klebsiella pneumoniae as an ESBL, quantity occasional, Pseudomonas aeruginosa occasional. The BioFire Pneumonia panel identified Klebsiella pneumoniae group with the CTXM and a bin value of 10 to the 5th. Pseudomonas aeruginosa with a bin value of 10 to the 4th. Now, they identified Candida albicans, but of course, this is not on our panel. In a BAL, Staph aureus as MRSA 10 to the 5th. We had Staph aureus, MEK-A positive, MREJ positive, 10 to the 6th. Pseudomonas aeruginosa, 10 to the 5th. We identified it a greater than or equal 10 to the 7th. And both identified Acinetobacter baumannii complex, their quantification at 10 to the 5th, and ours at 10 to the 4th. In the third specimen, the BAL, our Haemophilus influenza correlated quite nicely. We do not report normal flora, and we do not report yeast. In the fourth BAL, they detected Legionella pneumophila by PCR. We detected Legionella pneumophila. And in the fifth sample of BAL, again, you could see very nice concordance with the bin values within a 1 log range of each other. The other thing that was consistent also throughout the evaluator program, much like what we saw in the clinical studies, is that we certainly will have more detections with the pneumonia panel. So, for example, the first BAL, they had Klebsiella oxytoca and Pseudomonas aeruginosa at 10 to the 3. We identified both at 10 to the 4th, but we also identified E. coli at 10 to the 4th, Moraxella catarrhalis at 10 to the 4th, and human rhinovirus enterovirus. In the second BAL, we do not detect Candida species, but they did not report a Haemophilus influenza and a Staph aureus that we detected, and also a Mycoplasma pneumoniae. And in the third sputum, again, we do not report normal flora or yeast, but we also detected in the pneumonia panel Haemophilus influenza, Streptococcus pneumoniae, Streptococcus agalactiae, and human rhinovirus enterovirus. And in this last grouping here, of course, we will have discordant results with culture. So if you take a look at the first sample, which is a sputum, they had identified strep anginosus. That's not on the panel. We identified Pseudomonas aeruginosa. They identified Pseudomonas aeruginosa within a bin value of each other. They identified Enterobacter cloacae. We also Enterobacter cloacae complex. Staph aureus in the second BAL was at 10 to the 3, and we did not report this, but remember, that is less than the detectable limit where we have the lower edge of the 10 to the 4th bin set at about 10 to the 3.5. There was Haemophilus influenza. They reported at 10 to the 5th. We did not detect this, and this could have been an example where we did miss a positive in a particular specimen. And then normal flora, of course, is not on our panel. In an ETA, they detected Klebsiella oxytoca, again at 10 to the 3. That's below our lower limit of detection, so it would not be reported. And the same for the fourth ETA, Enterobacter cloacae, not reported below our lower limit of detection. And again, we do not report out normal flora. So hopefully this will give you some idea of some of the instances that you will have to learn how to interpret when you start to implement the pneumonia panel. There was a very nice subset from the clinical study data that looked at the potential impact of the pneumonia panel on patient outcomes. And this was a study that was presented by Dr. Blake Buchan, and it was conducted at the Medical College of Wisconsin. They looked at a total of 259 of their BAL specimens that were collected prospectively. The residuals were tested on the BioFire Pneumonia panel. They compared their results to their standard of care methods, including bacterial culture. They did do some PCR based upon what the clinician ordered on that particular patient. They conducted chart review to determine the type and duration of antibiotic therapy for each subject, and then they looked at hypothetical changes to antimicrobial therapy based on the BioFire Pneumonia panel were assessed and adjudicated. What they felt was that the panel may certainly help us more specifically target antibiotics. So some of the potential changes are listed here. So culture confirmed de-escalation could have involved 206 antimicrobials for 48% of the patients for over 18 hours of antimicrobial subscription hours. Culture confirmed escalation, which would have been in about 2% of the patients for 184 hours. So these were changes that would have been made based upon the BioFire result that were confirmed by culture. The next group were culture discrepant de-escalation, where we identified or didn't identify a pathogen, and that was different from the culture results. And that was in roughly 2% of the patients. For those, there were 3 organisms or 3 resistance mechanisms identified by standard of care, but not the pneumonia panel. In the next group, culture discrepant escalation or continuation, this was when organisms were identified by the BioFire Pneumonia panel, but not by the standard of care. And they may have represented normal oral flora or a true pathogen, we don't know. But that would have involved 17% of the patients, and overall, no change would have impacted 31% of those patients. So one of the questions was, are PCR-positive culture-negative samples clinically significant? So there were 42 cases identified where the BioFire Pneumonia panel identified an organism that would have continued or broadened therapy. However, the patients may have been on antibiotics at the time of sample collection. Discrepancies could have been caused by a fastidious pathogen that was difficult to culture. And culture results could have reported normal oral flora when a causative agent may have been present. So again, we need to keep in mind that the BioFire Pneumonia panel needs to be used in conjunction with the entire clinical picture, including culture results, and very importantly, in knowing if the patient was on any antibiotics, the type of those antibiotics at the time of sample collection. That could certainly have an impact on the culture results, but not on the BioFire Pneumonia panel results. They looked at the potential for antimicrobial de-escalation, which is something that we would all like to do when appropriate. And they found up to 50% of the patients could have had an antibiotics or more than one de-escalated. This would have been over 18,000 hours of antibiotic use. Antibiotics could have been removed 3 to 4 days earlier in 50% of the patients, with vancomycin representing 62 of the cases. If you take a look at the figure on the right, you can see that this affected basically almost all classes of antibiotics. It affected vancomycin, broad-spectrum piperacillin tazobactam, meropenem, azithromycin, cefepime, ceftriaxone, linezolid, levofloxacin, and others. And vancomycin and piperacillin tazobactam one of the most common empiric therapies that we see, accounts for 58% of the antimicrobial adjustments. And these could have been discontinued based on negative BioFire Pneumonia panel results for MRSA and for the Enterobacteria ACA. And of course, this has a major impact in allowing us appropriate antibiotic stewardship. So antibiotic use could have been reduced on an average of 6.2 days per patient. And in realizing that, we also need to think about, it was not measured in this study, of course, this was a retrospective look back, but also some of the downstream consequences of extended antimicrobial and broad spectrum therapy, such as the incidence of Clostridium difficile disease. So the clinical interpretation of the panel, the potential value of semi-quantitative bin reporting to help determine the clinical significance of the pathogens or resistance markers reported needs to be established by the individual testing site in consideration of your current testing practices. Sites may report differently depending upon patient populations, such as the ICU. Do you have transplant? This all needs to be considered. Reporting interpretation can be patient institution specific, and guidelines should be established and local education facilitated by joint decisions between the various clinical care groups. And really, this should be a team effort between the laboratory, infectious disease, pulmonologists, intensivists, infection control, your pharmacy group, and your antibiotic stewardship committee and your program to make these decisions. The users must understand the differences between PCR and culture. Your traditional reporting numbers, 1 plus 2 plus, rare, few, moderate, 10 to the 4th, 10 to the 5th, are not necessarily proportion to the new bin values. The detection of live organisms in cultures versus nucleic acid, where we will detect both live and dead organisms. You have to understand the effect of antibiotic treatment on culture results versus detecting it by the panel. And then the sensitivity and specificity of the panel versus standard culture. And keeping in mind, very important, this test does not replace culture. Culture is still required for the identification of pathogens not on the panel, and very importantly, for comprehensive antibiotic susceptibility testing. And just finally, a few important reminders. The BioFire Pneumonia panel does not require a gram stain to be performed prior to running the panel. However, laboratories should follow current good standard practices for determining, much like we do with sputum cultures, which samples would be acceptable or not acceptable for running the pneumonia panel. Semi-quantitative values or our bins are not absolute quantification. They're not the same as the same type of viral load you get when you do an HIV or an HCV viral load. But they're reported in a log bin with plus or minus about a half a log variance. Although there is comparison data to culture, the interpretation of the bin value in relation to culture needs to be established by the institution based upon their current methods and clinical findings. The clinical significance of the bin value reported needs to be established in this manner. Many variables affect the results, such as antibiotic treatment. And then finally, this test is not intended to be used to monitor patient response to antimicrobial therapy. So in summary, the BioFire Pneumonia panel, we know that pneumonia can be very severe disease. It can have high rates of morbidity and mortality. And in consideration of our CAP guidelines and other recommendations, we know that antibiotics need to be quickly started in these cases. And most importantly, we want to start the patients on the most tailored and accurate antibiotic. Traditional microbiology is still very important, but it takes days and it can be often negative. And therapy chosen empirically, unfortunately, many times can be inappropriate. And hopefully this panel will help guide us in making these more appropriate therapeutic choices. We'll have a rapid, reliable pathogen identification in a much faster manner that can definitely enhance our ability to diagnose pneumonia and support the clinical microbiology in also providing additional information to supplement their culture results. So with that, I'd like to stop and say thank you. I hope that you've learned something about the BioFire Pneumonia panel, and we look forward to sharing more information as a number of research studies are now being completed, looking at the clinical impact and interventional studies of the pneumonia panel in our patients with lower respiratory tract infections. Thank you.